Hello, everybody, and welcome. We'll just make sure we'll wait a little bit while everyone is joining. Perfect. Okay, we've got a couple minutes, so we'll just keep. Welcome, everybody. We're going to get started in a couple minutes. Welcome, everyone. So it's 7 o'clock while everybody's rolling in, and there's still some people joining. We've got a bunch of people on. Welcome to tonight's webinar, Myths and Misconceptions in Heart Health. I'm really excited about this one. We've got a great panel together. We're going to have lots of really good conversations. Before we start, I'm going to put up a poll. So if you feel comfortable, I'd love for you guys to fill out the poll so we can get an idea of kind of some common misconceptions that you're facing. And so that can help guide some of the questions and the conversations that we're going to have tonight. So I'll put that on. Can everybody see the poll? Should be launched right now. So I'll keep that up. Perfect. Okay, so let me see. I'm gonna relaunch the poll. Let's relaunch this. Let's see. Can you guys see that now? Perfect. Okay, perfect. Excellent. So while we're waiting for a couple extra people to roll in, feel free to go through the poll, just so we can get a good idea of where everybody's at. So for those of you who are just joining us, I just put a poll up to get a gauge on some questions. So please feel free to answer those before we get started. Okay, the answers are really interesting already. I think we're going to have some good discussions. So I'm going to leave that on as we start to go through. Feel free to answer it so I'm getting the live updates. So tonight's webinar, like I said, myths and misconceptions in heart health. We're having an integrative panel, so we'll have lots of great discussions. Today, the reason we're doing an integrative panel is there's more health information than ever. There is so much information online that we're seeing all the time. Yet in clinical practice, and I know that Dr. Adam and Dr. Banihashemi see this as well, there is a lot of confusion. There's a lot of noise. It's hard to understand which information to trust. So we've put this panel together really so that you get a bunch of different perspectives and different views, and you can start to really gauge where you're at and understand where your support should be. And it's interesting, the first question on the poll was actually, have you ever stopped medication because of something you read online? And 35% of you said yes, which is, quite an interesting statistic. And 11% of you said almost. And so again, I think this is something that is really important that we have a conversation about today. So an introduction to our panelists. I'm Dr. Emma Pollon-MacLeod. I'm a naturopathic doctor. I've been in clinical practice for 10 years. I focus on women's health and hormones. I'm a Menopause Society certified practitioner. I have a background in biochemistry, and I'm also the CEO of NutriChem. I have with me Dr. Banihashemi. He is a compassionate double board certified cardiologist with advanced training in echocardiography and nuclear cardiology and over 10 years of clinical experience. He's a graduate of the University of Ottawa Faculty of Medicine and completed his internal medicine residency at the University of Toronto and fellowships in cardiology and echocardiology at the Ottawa Heart Institute. With a strong interest in aging, age management, and holistic preventative medicine, he provides comprehensive, personalized, and high-quality ground care grounded in extensive clinical experience. So thank you so much for being part of our panel tonight. We have Dr. Adam Livingston. Dr. Adam is NutriChem's Director of Science. He's our designated pharmacy manager, a compounding pharmacist, and clinical pharmacist. His background is also in biochemistry from Queen's, and he is also from U of T at pharmacy school. He supports patients navigating complex medication decisions, deprescribing, and therapeutic alternatives. As deprescribing program coordinator, he helps patients safely reduce or discontinue medications that may no longer be serving them. He brings a practical, safety-focused lens to medication use, interactions, and real-world decision-making. So really good different views panelists for tonight. So I'm going to end the poll now because we've got the answers we need. Okay, so before we dive into the panel discussions, just a little bit of context as to why heart health. We're putting out a lot of content right now for heart health. February is Heart Health Month, and there is such a big impact on heart health in the community. We know it's a second leading cause of death. We know 1 in 5 adults are living with some sort of symptom like high blood pressure or some sort of risk factor. We also know that it's silent and it's hard to detect. The University of Ottawa Heart Institute is also just put out of an initiative, 1 million Canadian hearts, that's really pushing the narrative about early screening, having these conversations, and helping to understand your cardiovascular health and where your risk factors lie. So, it's a really important topic and it's very common. So this is why, we're really putting this in the forefront today. So tonight should be about 45 minutes of discussions. We've left about 15 minutes at the end for a live question and answer. So as we go through, feel free to put your questions into the chat box. We'll have our admin kind of filter them through to us. We'll answer those more at the end because most likely we might have answered your question as we go through. We're going to give a little bit of background on the heart and heart health, and then we're going to get into the panel discussion. Just to note that this webinar is for educational purposes only. It is not to provide personalized medical advice, diagnosis, or treatment. And the information shared today is not to replace consultation with your qualified healthcare professional. Please avoid sharing highly personalized medical details in the chat, in your questions, to protect your privacy. This event is being recorded and it will be sent out post the webinar. So heart health, just really basic. This is an ode to the heart. The heart is a muscle. It never stops beating. It beats over 100,000 times a day. It circulates blood, nutrients, oxygen to every organ. It's got to adjust its output based on activity, stress, and demand. Your brain, kidneys, all muscles and organs depend on healthy blood flow, and your heart never stops. So it's really important that we take care of our heart. We focus on putting less stress on our heart, and we're proactive because you only have one heart and it doesn't take a break even for a second. And lastly, before getting into the panel discussion, we wanted to talk about the prevention treatment spectrum. So this is a really important slide, and we're going to refer back to this, or I'll probably refer back to this as we're talking, just so that we understand where different parts and conversations are applicable. So, of course, in prevention, there's core preventative factors: sleep, nutrition, movement, exercise, diet, stress that apply always. They're always core foundational pillars to health. And these are the core foundational parts to a healthy cardiovascular system and healthy heart, healthy body. So when we talk about early intervention and medical treatments, we are always having this kind of core foundational piece. This doesn't replace medical treatments and it doesn't replace early interventions as we start to see shifts happening. So we want to make sure that you, as you're listening, you have a frame understanding, does this fall into prevention? Does this fall into early intervention where there's limited risk? Or does this fall into medical treatment where there are quite significant risks and now we need to lean into kind of more of a treatment zone? And understanding where you fall on the spectrum is an important part of deciding what's going to work for you. And that's what personalized medicine is really all about. So let's dive into our panel discussion. So the first topic we're going to talk about is cholesterol. And so it's interesting. So Ben, I'm going to ask you a question. Dr. Banihashemi, I'm going to ask you cholesterol, what is it and why does it matter? But first, I'm going to give you some context from the quiz, actually, the poll that we put out. So the question was, when you hear high cholesterol, what was your first thought? And the majority of people, which was great, they said it depends on the full picture. And a lot of people, so over 30% said, I'm not sure what my numbers mean. Some said it's dangerous and must be treated. And some said, I think it's fine. So big even spread around kind of understanding the relevance of cholesterol. So why don't you tell us a little bit about what is cholesterol?
Well, thank you, Emma. I really appreciate this opportunity to chat tonight, and I'm really excited, and I'm glad that we have so many participants. So hopefully everybody will take something out of the discussion tonight. Yeah, so with regards to cholesterol, first of all, kind of quickly understanding what cholesterol is, it's essentially a essential molecule in your body. It's belongs to a family of molecules that are called sterols in general. So there's a type of lipid, it's a type of fat made up of carbon, hydrogen, and oxygen. So every cell in your body has cholesterol. Cholesterol is actually an extremely essential, important part of the structure of every cell membrane. So essentially, the shell that surrounds every cell in your body is primarily made up of cholesterol. So it is an extremely vital, important molecule in our body. So really what we talk about tonight and we're going to focus on is cholesterol particles. Because cholesterol doesn't dissolve in blood because it's a fat, just the same way that if you put olive oil in the water, it's going to float on top. The same happens in your cholesterol in your blood. It doesn't dissolve in your blood. So in order for it to move around your body, it needs to be packaged into these cholesterol particles. And that's how it goes from your liver to different cells in your body. And those is what we're going to talk about tonight is actually focusing on the cholesterol particles, good cholesterol particles and bad cholesterol particles. I often hear these terms from my patients or on social media where people talk about good cholesterol and bad cholesterol. That doesn't exist. Cholesterol is cholesterol, and cholesterol is essential for your body. Really, what we're talking about here, when we talk about good cholesterol and bad cholesterol, we're talking about good cholesterol particles and bad cholesterol particles. And as this picture shows, bad cholesterol particles is the sticky cholesterol particles. They're the ones that stick to the wall and cause plaque. cause what we call atherosclerosis, which is a fancy term for plaque formation. You hear about calcium in your arteries, that's plaque. I mean, we can kind of go into the details of how the plaque is formed, but one of the building blocks of a plaque that ultimately leads to heart attack and stroke is these sticky cholesterol particles, bad cholesterol particles sticking to the walls of your arteries and over time accumulating, as you can see in this picture, and ultimately rupturing. And rupturing of those plaques is what leads to a heart attack and stroke. So that's kind of hopefully puts everything a little bit into context for everyone.
Hmm. Can you go into a little bit more of like how long does it take for, a cholesterol plaque to build up? Is this something that, when you first start to see cholesterol levels rise, you're instantaneously building plaque? Or is it, years of exposure to these higher levels?
Yeah, I'm glad you asked. So it definitely takes years and years. So by the time we see evidence of kind of what we call macroscopic plaque, so the type of plaque that we see with the naked eyes on some sort of an imaging, whether it's a coronary angiogram or a CT scan, by the time it gets to that level where we actually see the plaque, it takes at least a decade, if longer, to get there because there's a whole cascade of events that needs to happen once your cholesterol is elevated for it to cause your cholesterol particles, your sticky cholesterol particles to increase. Then it takes a very, very long time for your sticky cholesterol particles to stick to the walls. And the way that happens, it's a kind of what we call homeostasis, meaning some of these cholesterol particles stick to the wall, but your body has all of these defense mechanisms to kind of take them out of the walls. Um, and that process actually goes on for a long time until you have enough accumulation of those cholesterol particles for your body to mount an immune response to it. So, I mean, one of the things we're going to talk about maybe a little bit later, you constantly hear about this concept of inflammation in your arteries. The reason inflammation matters is because you don't form plaque without inflammation. Once the cholesterol particles stick to the wall, your body mounts an inflammatory response, and that inflammation is what makes those cholesterol particles eventually turn into plaque. But that takes years for it to happen. And there's many different kind of processes that are involved in that. So it's your cholesterol, it's your blood pressure, it's inflammation, is the endothelial function, which is kind of that lining inside of your arteries, which you can kind of see in this picture where the cholesterols go and get dislodged in that wall. So all of those different aspects and some of the stuff that we're going to talk about tonight is going to reflect on all of these different steps that are involved to go from high cholesterol to developing plaque in your arteries.
Hmm. And is there a direct correlation between, LDL or LDL levels and plaque formation? So is it almost like linear that if your levels are above a certain level, then you can almost guarantee that you're making plaque? Or does it depend, as you said, on other factors such as inflammation? Like where does is blood pressure a result of that, or is it causing it? Like what are the other, pieces of the puzzle that, people will want to kind of understand beyond just one number on blood work?
Yeah, so that's a great question. And the short answer is it depends. It is extremely multifactorial, right? So in my longevity clinic, I have patients that are super athletic. They come with the LDL cholesterol of 5, and we do a CT coronary angiogram on them, and they have zero plaque. And then we have other patients that could have a LDL cholesterol that is significantly lower at 3 or 3.5, but they have all these other comorbidities, all these other risk factors like elevated high blood pressure or extremely high inflammation or insulin resistance in the form of diabetes or prediabetes or metabolic syndrome, and they have significantly higher plaque burden. So really your LDL cholesterol and your cholesterol particles is just one part of this long equation that leads eventually to plaque formation.
Okay, yeah, and that's super helpful to put it into context because I think, especially when we see, levels on blood work, it can feel really jarring when you see that H, that high out of range, and people can be like, oh my God, does this mean I'm going to have a heart attack tomorrow? And I think, that's why we're having this conversation because it's really about, years exposure. And on the alternative side, how do you, when someone said, well, I've always had high cholesterol, I've had it my whole life. Nothing's ever happened. I feel fine. What are the types of conversations you're having with people around, understanding the risks a little bit more?
Yeah, so really what's considered elevated is very much individualized, right? Because, and you both know this very, very well. We basically do a complex risk stratification strategy on patients to figure out what cardiovascular risk level they're at. So if somebody's considered low risk based on different types of risk scoring that we do on them, then we allow for actually a much higher LDL cholesterol before it becomes problematic, right? So it is very much a personalized question. So a cholesterol, an LDL cholesterol that would be elevated for a 65-year-old after a heart attack would not necessarily be an elevated cholesterol for a 25-year-old who is otherwise healthy. So it very much depends on your level of risk. And LDL cholesterol particle is definitely, even when it comes to cholesterol story, is not all of the story because, as you know, we have other genetic factors like, for example, lipoprotein A, which is a protein spike that sits on primarily your LDL cholesterol particles and it makes them essentially more sticky. So you can have two people can have exactly the same LDL cholesterol particle. If one of them has a significantly higher lipoprotein A, for example, then their LDL cholesterol particles are significantly more sticky. So they are much more likely to have plaque. So we essentially, on every patient, we do this kind of personalized risk calculation to figure out whether their level of cholesterol and their level of risk, where they're at, and are they at a level where we are concerned enough to start treating that LDL cholesterol to modify their risk and reduce their risk of heart attack and stroke.
Yeah, and that's interesting that you brought that up. So that's one of the questions on the poll. So do you know your ApoB or lipo-A levels? And 30% of people said, I have no idea what that is. 40% of people said no. 20% of people said yes, and then 10% said I've heard, but I'm not sure. So I think this is one of these new markers, and maybe not in your field, but at least, in general medicine and clinical practice, it's definitely, there's not a lot of people talking about lipo A and ApoB. Do you feel like this would be helpful for everybody to have alongside their cholesterol levels tested?
Yeah, 100%. So, I mean, lipoprotein A is a very easy blood work test that can be ordered by any healthcare provider, and it is easily accessible in any laboratory across the city. And it is a marker that you only need to check once in your lifetime because your lipoprotein A levels actually remains fairly stable, plus minus 10% across your life. And it is something that, as long as you have that kind of simple blood work done once, it can significantly predict your risk of developing heart attack and stroke. So I recommend it for anyone over the age of 40 to at least get their lipoprotein A checked at least once. And with regards to the ApoB, it certainly has a role. It particularly has a role in people who have elevated triglycerides or metabolic syndrome because your level of bad cholesterol particles are essentially determined by your ApoB levels. Now, in most people who have normal cholesterol profile, that kind of tracks or correlates relatively well with your LDL cholesterol. But as soon as you go in a little bit of a kind of an outlier territory where people develop high triglycerides in the context of metabolic dysfunction, which we're going to talk about later tonight, in those people, ApoB is very helpful. And again, as a baseline, it's very helpful. So I kind of recommend everyone, if they have never had their cholesterol checked and they're over the age of 40, and arguably now the guidelines are changing that we should probably even start doing it in people in their 30s, particularly in people who have a very strong family history of early heart disease. We should be checking their lipoprotein A and their lipid profile even before the age of 40. But for the general population, definitely once they're over 40, they should have ApoB, their LDL cholesterol, and their lipoprotein A, along with some of the metabolic markers that maybe we'll talk about later in this evening.
Super, super helpful. And I think this is new information that, we're just not talking about enough. And this is part of the prevention kind of bucket, let's call it, because you're understanding and assessing that personalized risk. Dr. Adam, I'm going to jump over to you because when we talk about cholesterol, it's hard to talk about cholesterol without bringing up statins. And statins are a bit of, I think one of the topics that there is a lot of nuance. There's a lot of information online. We polled everyone and asked statins are 11% said life-saving, 30% said overprescribed, 21% said necessary but risky, and 40% said I'm not sure. So there's a really wide spectrum of, and only 11% are saying kind of life-saving. So why don't you, Dr. Adam, if you could just tell us a little bit about what actually is a statin?
Yeah, so excuse me. Thanks, Emma. So statins have been around for decades. They've been sort of first line therapy for reducing cholesterol in patients for a long time now, heavily studied in the population in many randomized controlled trials. They basically work by inhibiting an enzyme called HMG-CoA reductase. What essentially that does, so HMG-CoA reductase normally is making your cholesterol. It is an essential molecule, like Dr. Ben mentioned, but when it gets too high, we can get into high risk territory. So statins basically go in and inhibit that enzyme from making cholesterol. And they can reduce LDL cholesterol or bad cholesterol, typically anywhere between 30 to 55%. And when they were first introduced, they were amazing for what's called secondary prevention. So they can drastically reduce the risk of things like heart attack and stroke after someone's already had one. Um, so when they inhibit this HMG-CoA reductase pathway, they can reduce cholesterol, but one issue with them is that they also reduce production of something called CoQ10 or coenzyme Q10, which is why we see one of the main side effects from statins being basically like myalgia or muscle pain. And that's because CoQ10 is very important in your muscle cells and the mitochondria, the little powerhouses in your muscle cells, for producing energy. So when we inhibit this cholesterol pathway with statins, that's why the most common side effect you see is a little bit of muscle pain. Now, sometimes there's a bit of fear or misinformation around statins, which I think is not fair considering they're very often the benefits highly outweigh the risks, and they've been so heavily studied. So they are very, very effective in reducing LDL or bad cholesterol, and generally very well tolerated. The main concerns I hear from patients with statins are the muscle issues. So when we look at the studies on that, myalgia or muscle pain from statins, it's typically only in about 5 to 10% of patients. And I see this as well, like in the pharmacy and the clinic. So about 1 in 15 patients will have this. It's typically when you start on a statin, and it's typically when you increase the dose or get up into higher dose statins. So in general, very well tolerated. The other concern I hear from a lot of patients is that there's, reports that there's cognitive effects from statins. But when we look at big data meta-analyses, there's no more so than placebo. So I think sometimes people are sort of noceboing affecting, or they've heard things and think this is a side effect, when really, sometimes there seems to be a little bit of maybe controversy around statins, but I don't really think there is. I think where people sort of claim that they're overprescribed maybe is when patients are getting into like primary prevention, where maybe they don't have high, cholesterol or high LDL, but they have other risk factors. So the doctor makes a, benefit to risk decision of maybe you have a strong family history, maybe you're getting older, you're a male smoker, metabolic syndrome, you're heavily overweight or something, and the doctor might want to put you on a low dose statin, for example, like a Crestor 5 milligram, just to limit the risks. And I think patients see that and say, well, I don't have high cholesterol. This is overprescribed. Why are they giving this to me? And it's because there is an association with reduced risk of cardiovascular events in what's called primary prevention. So you haven't had a heart attack or stroke. Why the heck is he, and I don't have high cholesterol necessarily. Why are they giving me this statin? And it's because, they've looked and assessed other risk factors, and a low dose statin can still be helpful there.
Yeah, and I think it's interesting because I see this in my clinical practice that, if a doctor is assessing other risks, they might not be communicating it. So I think a lot of people maybe in primary care, it's an easy win to be like, oh, your cholesterol's high, let's prescribe you medication. People don't understand like why they're being prescribed. There's no advanced personalized testing done. There's no discussions of other options. So I think there is kind of a lot of missed kind of information in between, and that's what I hear in my practice. And I know I'm sure Dr. Banihashemi, you can speak to this as well. And it's very interesting, the results on the poll. The question was, if your doctor recommended a statin, how would you feel? 11% said comfortable, 32% said hesitant, 36% said concerned about side effects, and 21% said I would decline. So I think it's important to understand like why are these, and it's not this is not a webinar on statins. And I think it's actually a webinar on personal choice and being informed and understanding your risks and understanding your benefits. And, um, and so Dr. Ben, where do you see statins playing into a treatment plan? Like, where does this fall into play for people, and where are they like required, essential, like no question versus where is there some wiggle room, playing ground? Curious as to your thoughts on that.
Yeah, so I would say the no-brainer, definitely in my practice as a cardiologist, are people who've already had a cardiovascular event. So if somebody has already had a stroke or they've already had a heart attack, essentially the data is very, very clear and very, very black and white that those people would significantly benefit from being on a statin. So nobody, I think if you see any argument about that, people are just being misinformed because the evidence is completely, completely clear on that, that any sort of possible side effects of statin, the benefits would far outweigh that. So that is kind of, I think, one part of the conversation that is very, very black and white for every healthcare provider that is familiar with the science and the evidence and the clinical trials. I think once it becomes a little bit more controversial, although there's less and less controversy even in that department, is really with primary prevention. So when we are talking about, and what we mean by primary prevention is these are people who have not had any sort of cardiovascular event. They've never had a heart attack. They've never had a stroke. They've never had angina. In those people, there has been a lot of debate as to what is the threshold of treatment. At what level of elevated cholesterol, at what level of LDL cholesterol should we initiate statin? And I think there is maybe still some discussion with regards to what level it is. I think if you're clearly a high-risk patient, and again, we have different tools to assess patients' risk when they haven't had a heart attack or a stroke, because if you have had a heart attack or stroke, you're automatically high risk. But there are other modifiers, other comorbidities, risk factors that would allow us to re-stratify you. And if based on the risk scores that we have available, if you fall into the high risk category, I think now we even have pretty solid evidence that in high risk patients, if their LDL cholesterol is beyond a certain level, they would definitely benefit from a statin. Once you're an intermediate to a low risk, it becomes a little bit more controversial. Certainly in low risk patients is very controversial. If somebody is in a low cardiovascular risk level, with whatever risk score we categorize that, whether it's Framingham risk score or any other risk score that we use, if somebody is in low cardiovascular risk, no matter how elevated their cholesterol is, it is a little bit of a controversy as to, what level is too high, what level of cholesterol is too high, where we need to actually move to pharmaceuticals. Of course, statin being the first line therapy for it. So yeah, I would say definitely post heart attack, stroke, high cardiovascular risk. Those are black and white. Intermediate risk, a little bit gray, and definitely the low risk patients is even more gray.
And I'm going to ask one more question before we kind of move on from the cholesterol, because it will come up in all the other topics. So you're talking about how high is too high, but how low is too low? Is there a discussion around that? Because if we, talk about how cholesterol is an essential part of every cell membrane, it's the backbone of all of our steroid hormones. Are we, overly thinking that there's no basement and requirement of cholesterol? Like, is that something that you talk about, or there's more research on it all of a like when it's actually risky of getting too low?
Yeah, so it's interesting that you asked this question because up to very recently, with the new agents that we have now beyond statin, we never really had to ask that question because we could never really drop people's cholesterol in 95% of people. We could never, even on high dose statin, even if we add additional therapy, we were really not able to drop the cholesterol to a levels where we would be concerned. But now we have these new agents where we're not going to have time to talk about tonight, but they're essentially these biologic agents called this group of drug called PCSK9 inhibitors. So with PCSK9 inhibitors, now we see in combination with statin extremely low LDL cholesterols, where this kind of question of how low is too low has again kind of come back a little bit to the discussion. My simple answer to that is in 99% of patients, I wouldn't be concerned about that. And really, the argument with that, when you talk about the cholesterol expert, is that if you look at young adults and actually children, their ApoB levels, which is kind of the gold standard as we talked about, their ApoB levels could be as low as zero point 0.3. And this is during their phase of life where they are still growing, their nervous system is still growing. So I'm sure for those of you who've read about statins and controversy around statin, people talk about increased risk of dementia and Alzheimer's. By the way, all of that has been debunked. Statin does not increase risk of Alzheimer or dementia. But a lot of this was around this idea that your nervous system, your neurons need cholesterol. So if your cholesterol goes too low, maybe you have demyelination, which is kind of degeneration of your nervous system. But really the counter argument to that I've heard from a lot of cholesterol experts is that if you look at young kids where the neurons are still growing, their nervous system is still growing, their ApoB levels are extremely low at the levels that we would never get our ApoB, even on medical therapy. So I would say for a majority of people, I would not be concerned about too low of LDL cholesterol as a cause for harm.
Okay, and I think that's interesting that they're starting to kind of bring this part of the conversation in. And I think it's another piece of why the personalized conversations and assessing individual risk is so important so that, people feel comfortable knowing why they're taking something, and they're also not getting put it on something that they might not require, because they've really done a lot of the lifestyle work to modify all of their other risk factors. So I want us to be like, we knew that was going to be the core part of the conversation. And we're going to kind of jump back to a lot of the things that came up around cholesterol and atherosclerosis. What I'm going to give a little bit of background on. This is our next big question. What are the impacts of menopause on heart health? And this is actually how Dr. Banihashemi and I connected is, I do a lot of hormone therapy in my clinical practice. He's a cardiologist, and I was talking about my patients that it was tricky because I see the impacts of the loss of estrogen. We have estrogen receptors all over the body, all over our blood vessels, in the heart, bones, everywhere. So as estrogen levels significantly decline post-menopause, we see a lot of shifts happen in our cholesterol profile. We can see increases in blood pressure, but there's also a lot of the symptom changes that can happen. So menopause itself isn't causing heart disease and stroke, but it's the risk factors that can start to accumulate, especially in women post-menopause. That's where a woman's cardiovascular risk really start to rise post-menopause, because we don't have that protective effect of estrogen on the heart. And so, you have all those other risks we were talking about. It's not just about cholesterol, although cholesterol levels do increase post-menopause, which is interesting. I actually think 43% of people said in the poll said, have your cholesterol and blood pressure changed since perimenopause? Yes. 43% of people answered yes, 24 no, 25 I don't know, and I haven't checked. So if we're talking about menopause and we're talking about the symptoms of menopause, like disrupted sleep, the weight and metabolic like changes, weight more gain in the middle, the hot flashes, the night sweats, those are the symptoms that can have a really big impact, low energy, but beneath the surface, there's also changes that are occurring that oftentimes we're not really measuring or talking about. We're focused on the symptoms, that's important. But there's also, we need to understand how things are changing, and now your body's in a bit of a different zone. So, um, oops. So that's something I wanted to chat with you about, Dr. Banihashemi. Where do you see estrogen and heart health, and what's the connection between the two?
Yeah, so I'm very excited about this collaboration that we're doing together because this is one of a kind, has never been done. Kind of basically a women's health specialist and a cardiologist kind of working together for women in their midlife and trying to kind of re-stratify them better and help them through this journey of perimenopause and menopause. And the reason this is so important is because we know estrogen has a significant cardioprotective effect. So estrogen definitely brings down blood pressure, and that is through various different mechanisms. It has significant effect on your vessels in the endothelium, which is something that I talked about at the earliest part of the conversation. Endothelium is essentially the lining inside of your arteries, and that's where all the action happens. That's where the plaque forms. That's where your risk of heart attack and stroke goes up. So that endothelium is very much affected by estrogen. There are estrogen receptors there. And endothelium is what actually determines a function of your arteries. When we talk about stiff blood vessels, a lot of that is really talking and referring to your endothelium. So we have this basically, and I don't want to go into a lot of the physiology of it, but certainly at the level of endothelium, your endothelial health is very much determined by estrogen. And then the other effect is, as you mentioned, is the effect on the lipid profile, the cholesterol that we talked about. So it increases as you kind of lose estrogen during perimenopause, your LDL cholesterol particles, which is your bad cholesterol particles, L for lousy, that's what I usually tell my patient, it goes up. Your HDL cholesterol particles, which are the good cholesterol particles and help clear the plaque out of the endothelium, HDL goes down. Your triglycerides, which is a measure of your metabolic function, it goes up with estrogen withdrawal. And your inflammation goes up and insulin resistance goes up. So insulin resistance, again, is a topic we're going to hopefully talk a little bit about metabolic
That's
function and the importance of metabolic function. But certainly withdrawal of estrogen, losing estrogen would cause insulin resistance. And of course, body composition changes that I'm sure many of you have experienced. So you kind of start gaining more fat in the middle, you lose muscle mass, and that further leads to metabolic dysfunction and insulin resistance, which again kind of increases inflammation, increases blood pressure. So it's almost like a vicious cycle with losing estrogen during menopause and increased cardiovascular risk.
hmm and I think, the information around hormones, we're kind of breaking down a lot of the misinformation and the fear around the use of estrogen and hormone replacement therapy. And one of the concepts, because I want to make sure we get into the metabolic health and some of the other topics, but before we move on to the metabolic health, is that the concept of replacing estrogen before your body has had a chance to adapt to the loss of it. And so this is what we call the window of opportunity. So especially when we're talking about cardiovascular health and we're talking about hormone replacement therapy, it's really important to understand, it used to be, that this is where someone says, oh, it's 10 years post-menopause or 5 years post-menopause. That's where the risks start to increase when you're reintroducing a hormone versus if you introduce it earlier on when you're in late perimenopause, very early stages of menopause, you haven't had the endothelial changes, you haven't had the plaque buildups, you haven't experienced all the changes that happen from the withdrawal. So I just really wanted to make sure that's a take home, that timing around hormones and heart health is a big thing. And again, that was one of the biggest factors in why we developed this program, is that there are a lot of women who nobody spoke to them about hormones. And so there's like a 5, 6, 7 year gap, from a purely blood work standpoint, there might be risks, but this is why we put them through a bit more advanced assessment so we can comfortably introduce hormones if required. So there's an impact. It's really on a lot of the things that we had talked about previously. And actually, this is a nice kind of segue into metabolic health because of the big impacts of hormones and menopause and metabolic health is such a big important topic when it comes to cardiovascular health. So, and I'm going to try to keep us flowing a little bit quicker here because we're already, we're going to have to shorten our question period.
Could I just, before we move on, Emma, could I just chime in for one sec, just as
Please,
the
please.
compounding pharmacist? Yeah.
Yeah.
The other critical thing I would say with HRT is you do get into riskier territory when you're doing hormone replacement therapy if you're using things like oral estrogens or synthetic progesterones or progestins. So those are associated actually with cardiovascular risk and issues. And that's why here we really promote and I really try to shift prescribers that want to work with hormones towards transdermal estrogens because it doesn't go through the liver and get converted to metabolites that can actually cause some cardiovascular risk. And I also love, bioidentical microdized progesterone is my favorite and very low risk for cardiovascular. So that's really what we promote in the compounding pharmacy and try to get prescribers behind because not all HRT is the same. And there's very cookie cutter sort of standard manufactured products out there where I love that we can make these better options for women dealing with menopause here at NutriChem because I can give them customized dosing of transdermal through the skin estrogens, which are much lower risk, bioidentical estrogen, and micronized typically oral progesterone is sort of the gold standard, I would say, for hormone replacement to limit cardiovascular risk and actually help with cardiovascular health. So I just didn't want you to move on before I said my
No,
spiel there.
good.
Not
That
all
I
HRT is the same. Yeah.
Actually, that's a good question because this is a question I get all of the time. So since you mentioned it, can you name like some of the commercially available products like estrogel or th those ones, I think there's a misconception that those aren't what we call bioidentical, that those are synthetic. So maybe you can speak to some of the commercially available products. Like what does hormone replacement therapy look like in terms of estrogen? From a commercially available product.
Yeah, so typically estrogel or Divigel are good bioidentical commercial products. And then there's also the Estradot patch are kind of my favorite on the commercial product side.
Okay.
I still prefer compounding because we can test and let's not guess and we can test and dose based on that and make it more personalized. But those are the main ones out there. And then there's commercial micronized progesterone as well, like Prometrium. Yeah.
Perfect. Yeah, I always get that question. My doctor gave me hormones. Is it still bioidentical? So I wanted to make sure we, covered that. Now, kind of swinging into metabolic health. And I know you already touched on this quite a bit that, when we talk about cholesterol and atherosclerosis, yes, there's the one kind of molecule cholesterol that we're really focused in on, but it's actually the environment in which the cholesterol is circulating through the vessels in that makes more of a difference. Adam, I'm actually going to ask you this first. Like, we all watched the Olympics. We all got bombarded
Always.
with
Ozempic,
Mounjaro, Ozempic,
Wegovy.
Wegovy,
Yeah.
every single commercial.
Yeah.
Can you speak a little bit to what are these medications? And then we are going to talk about why this is relevant, but can you speak to that? What is Ozempic and Wegovy?
Yeah, so obviously these are big blockbuster drugs. They do have very significant weight loss effects. The way they basically work, they work basically just like what's called an incretin hormone, which is GLP-1. But basically, it's a hormone released in the gut that binds up the gut, slows gut motility, and basically turns off hunger signaling. And basically, it makes you feel the way you feel after you've just eaten a meal, even if you've eaten nothing. So when I talk to a lot of patients on these medications, basically they're like, "Oh my, I just am not hungry ever." So it's much easier to follow a diet and restrict calories more and lose weight. So that's sort of the basic idea of how they work is they act just like a peptide or an incretin hormone that basically shuts down hunger signaling. And they basically go in and bind that receptor and basically turn down hunger drive. And meditate. I mean, they're very effective. They were originally, used for blood sugar control, and now they've moved into the weight loss zone of therapeutics. But they're very effective. Like Ozempic, typically in studies you see like 15% reduction in overall body weight. Mounjaro is even higher, like 20, 25% as high as that. So it can be quite significant and life-changing for some patients that have always struggled with this. So, the one issue I do see with them sometimes is, a rebound effect if patients discontinue if they don't do the lifestyle stuff. You do get some gastrointestinal issues with them. A big factor and a big thing I try to remind patients when they're on GLP-1 agonists is, you're not going to be hungry. So you have to be very conscientious of the fact that you don't want to basically like almost get into wasting, where some of these patients basically stop eating. And yes, you're going to lose body fat and lose weight, which is great, but you also can actually get into losing muscle and bone, which can be kind of dangerous.
And so so Dr. Banihashemi, I'm going to ask about the connection between then the weight. So when we talk about cardiovascular health, there's such a connection, as you said, between, weight in the middle, visceral fat, insulin resistant that, create this system in which your body is almost supercharged to make plaques based on, what you were saying, inflamed, resistance, high sugar. It's just a lot passing through. Is the weight loss the biggest driver or the biggest factor here, or is it actually inflammation and insulin? So what's the connection between, medication like a GLP-1 that would actually significantly reduce weight? Does that have a significant impact on cardiovascular health and risk beyond just weight loss?
Yeah, so I mean, GLP-1s are, I mean, quite incredible. I think, I mean, for us, there's a lot of cardiovascular drugs that have been kind of blockbuster over the last 10 years, but I would say across the board for almost kind of 80-90% of my patients, they're probably the first drug that almost make a difference almost for everybody,
Yeah.
in a sense. And it's because it is very multifactorial how they work. So certainly, as you said, I think the weight loss is important, but it's definitely not the full story. I mean, we have pretty good idea even on the GLP-1 agonists on the earlier generations, I should say, of GLP-1 agonists, where we did not see as much weight loss, you would still see quite a bit of cardiovascular benefit. So that kind of shows you that it goes beyond weight management. Now, of course, as Adam mentioned, with the newer generations like Mounjaro or tirzepatide, you have more weight control. You would also see significantly more cardiovascular benefits. So certainly seems like the newer generations, which are kind of a combination of GLP, GIPs, they have more weight loss, more cardiovascular benefit, but I think it's not a full story. And if you actually look at the mechanistic way that GLP-1 works, you have it in many, you have the receptors in many different parts of your body, including, again, your endothelium. And as a result of that, again, endothelial function is improved. We know that you have blood pressure reduction independent of weight change. You would see blood pressure reduction with these agents. We now have evidence in congestive heart failure. So we have multiple randomized clinical trials now with GLP-1s showing that in heart failure patients, it significantly reduces risk of cardiovascular death, risk of hospitalization with congestive heart failure. So it goes way beyond it. And I think if I want to kind of categorize it, it's kind of, I think it's weight, it's endothelial function, it's blood pressure. It is, of course, the insulin sensitivity aspect. So we didn't even talk about that. These drugs are primarily diabetic drugs. And we would see that kind of the weight changes are not necessarily correlating with the glycemic control or control of your blood sugar. So certainly the blood sugar control that happens as a result of them or the insulin sensitivity that happens, that again is a whole conversation as to how that reduces your cardiovascular outcome, but that does. They seem to have an anti-inflammatory effect. Now that anti-inflammatory effect could be driven by the fact that you lose weight and you lose visceral fat, but it's probably beyond that. So we're still finding out about all of these different avenues under which GLP-1 agonist helps your cardiovascular system, but it is many.
hmm And I think there's a lot of stigma around, these types of medication. And that's why we're here to have this discussion to be like, let's lay it all out on the table. Not everything falls into like first line, you need to do this right away. But what are people's options as you move, down the line and understand the barriers to you actually getting traction and making some shifts? And I think there's a lot of value in having extra support in an area where it's almost this like very vicious cycle that you can kind of get up against an extremely difficult kind of wall where you start to have blood sugar dysregulation, your appetite control and hormone signaling can come off. You start to gain more weight in the middle, you lose more muscle mass, further inflammation, further weight gain. So then you have people, who are like, I don't eat much at all. I have the same diet. I'm putting on weight. Like it's just, and they're doing all of the things. They know about protein, they're moving their body. And I think these are some of the tools we can talk about as clinicians to be like, well, this is where there's some evidence to use. And I'm a big fan of using microdosing and lower dosing of these initially to support people getting a little bit of extra that, push. And they're doing all the pieces as Adam mentioned. You still have to do all the foundational things. It's allowing your body to, have a little bit of extra support. But for some reason, when it comes to insulin resistant and metabolic disease and fatty liver, we feel personally responsible for the outcomes when often our bodies are on a trajectory that it's very, very difficult to do when you don't have extra interventions. So I'm going
I,
to keep, yeah.
I think for patients that have struggled with their weight and metabolic health, throughout their whole life and it's been a struggle, they can be great. Sometimes I think it can get a little inappropriate with sort of sometimes women especially want to lose just like 10 pounds and it might be a little inappropriate in that case, I find, but
Of course, there needs to be like you
like
should
sort of the
have.
cosmetic reasoning sometimes.
Exactly. Like if there's a reason and understanding, okay, do you have insulin resistance? Are you hitting a wall? Like this is where we were talking about like clinical for risk. Where does it kind of fit into the picture? And one of the questions, Dr. Banihashemi, we talked about this a little bit. We've already covered cholesterol. We covered ApoB, Lipo-A. Are there any other kind of key things that, if someone was like, how do I know? How do I know where my heart health is at? Like, is there anything besides those markers that someone should be measuring or aware of just to know on their own?
Yeah, so I mean, I think some of that depends on where you are in your life. So certainly, I mean, we're talking about menopause and perimenopause. I think for midlife women, as we talked about, I think an important take-home message is if you are in that stage in your life where you are actually dealing with menopause and perimenopause, just the fact that you have hot flashes, that should be an indicator to you that your cardiovascular risk has gone up. So this is almost an alert, an alarm that my estrogen is dropping, my protection is going away, and all these changes are happening in my body where my cardiovascular risk is going up. And certainly in those patients, I would strongly recommend that they would get a cardiovascular workup. And it could be very basic. I think a stress test in a perimenopausal woman is quite appropriate. Now, you might have some low risk perimenopausal women, but that is rare. In most women that are in that stage of their life, once they're over 50, based on the algorithm we do for their cardiovascular risk, they fall in that kind of moderate to high cardiovascular risk category where stress testing is quite appropriate. We don't recommend stress testing for low risk patients for a variety of reasons. So I would say stress test is always a good way to start. It gives us a lot of good information with regards to your exercise tolerance, which we know is a major prognostic factor. We learned about your blood pressure response to exercise, which is again a major prognosticator factor. We find out whether you have blockages in the arteries of your heart. So that's a very good appropriate test. For a little bit of a higher risk patient, we also recommend sometimes to do carotid ultrasound. And the reason for that is carotid ultrasound is a very good risk indicator for your risk of stroke. We can directly look at your carotid arteries and look at kind of your essentially even mild plaque in your carotid arteries. We are able to detect that. And we're able to do that for kind of an intermediate to high risk patients. And the other reason that carotid arteries are important because they're very similar vascular bed to your coronary arteries. So whatever is happening in your carotid arteries are actually a very good reflection of your coronary arteries, which are the arteries in your heart, which are much harder to look at. We cannot look at your coronary arteries without doing invasive testing. We can do a CT scan and calcium score, but the availability of that is quite limited. It's very hard to get. It's not available privately. If you want to go through the public healthcare system, it takes months to get it done. And that's the other reason that we use carotid artery, because it's a cheaper test, more accessible test, which gives us a very good idea about your vascular test. So those are the two tests that I would say for most patients that are perimenopausal and menopausal and have never had a cardiovascular test would be quite appropriate testing.
Mm.
And what about, and I know I know we're at time, but we're gonna go through the content and then we'll save the questions and we can send out some answers after. What about blood pressure? What about people measuring their blood pressure at home? Is that valuable? Should people be aware of their numbers? I mean, I'm a big proponent of telling people to know where they're at. Is this something you advise?
100%. I'm glad you brought that up. So I think it's very important. Again, as we get older, we know the blood pressure goes up, especially around the time of menopause and perimenopause with estrogen withdrawal, your blood pressure significantly goes up. And blood pressure measurements at home is actually the gold standard. It's a much more reliable physiological blood pressure compared to what your doctor measures at the office. So I usually recommend to the people to buy a blood pressure machine. Almost every single one of my patients, I recommend they buy it. It's like $100 and you would have it for 10 plus years. So it's a very good investment in your health to buy a good blood pressure machine, have it at home. And then I ask them to essentially do snapshots of time. So they don't need to do it every day. I ask them to pick a typical week where they're not on vacation, they're not particularly stressed, and then they do their blood pressure 5 or 7 days in a row, ideally first thing in the morning. And you want to do it 3 times in a row because the blood pressure is always high when you measure it first time. So you actually do it 3 times in a row, about 5 minutes apart. You throw away the first number and you average the other two number. That is what's recommended by Canadian Cardiovascular Society as to the gold standard or close to the gold standard for measuring the blood pressure.
Excellent. So know your numbers. So when it goes high in your doctor's office, you can say, this is a little high for me. I measure it at home. Um, we're going to move along to the supplements because there's actually a lot of questions around supplements. So I think we'll answer some of the questions as we go through this section. So where supplements fit in, we talked about we have a cardiologist, so we really wanted to talk about more of the kind of complex in the farm with Dr. Adam as well, like GLP-1, statins. Supplements can fit very well into kind of the intermediate risk. They're always adjunctive. Again, if you're high risk or you had an event, these are not replacing statins. They're not a treatment for a heart condition. But there's a lot of benefits to taking certain things if you understand why you're taking them and what you're taking them for. And I get these questions so much. This is why we wanted to put this information in this webinar, is that and I'm going to kind of quickly run through these. And Dr. Adam and Dr. Banihashemi, please feel free to jump in. Magnesium, best all-around supplement, highly underrated, really good. It's really helpful for sleep, and that's something we didn't even get to touch on is the role of sleep in heart health is can't, I'm sure you, I see you nodding. Sleep health is so critical to heart health. So if you're stressed, if you're anxious, you don't have a restful sleep, magnesium can be very helpful and very safe. It's not interacting with any heart medications for heart palpitations, muscle cramps. And there's actually some good research around blood pressure in normotensin and atherosclerosis. Again, in the very mild to intermediate risk area.
And magnesium bisglycinate in particular.
Yes, magnesium glycinate, or else we're going to give you loose bowel movements, and you don't want that. Adam, I'm going to let you speak to creatine a little bit because creatine itself won't, like, there's no research with creatine in the heart in particular, but again, we've talked tonight about metabolic health, muscles, insulin resistance, and this is a really big part of looking at the kind of core big picture. And, instead of focusing on supplements here with cholesterol, we should actually be utilizing them to help us build more lean muscle mass, support our appetite, bring in the protein so that we can shift that metabolic health a little bit more. So, Adam, what are your thoughts on creatine?
I mean, creatine is probably one of the best established supplements in terms of helping with muscular endurance. There's studies now where, typically it would be a 5 gram dose daily and you'd load it up to get better muscular performance. What it does down at the cellular level is basically help you reload what's called ATP, which is like the most basic energy molecule. So you're burning through ATP when you're using your muscles a lot or just your normal metabolism. Creatine basically helps reconvert sort of that used ATP, which becomes called ADP, back to ATP. So your muscles can basically fire more. If you've ever used creatine, I've used it, for weightlifting and things. it's great. You notice more reps and you feel stronger when you're working out. So it's a great way to increase energy and stamina, especially if you're trying to getting back into working out. 5 grams a day is pretty typical. Now there's actually studies where it can even help with things like cognition and if you've been sleep deprived or jet lagged, when they get up to even 10, 20 gram doses, sort of the higher doses. There's studies that it can actually help with like the cognitive function is a big part of it. And a lot of people don't think of the cognitive part of creatine, but your brain loves creatine as well and runs through a lot of ATP. Yeah, so I love creatine. Definitely one of my top recommendations.
And it's the same with protein again. Like this isn't directly going to help with cholesterol levels, but when we talk about core, where the supplements can really fit in supporting that sh lifestyle shift in the preventative zone, it's how do we support more exercise, more movement, better sleep, better blood sugar control? And so that's where these things can really fit into to support a healthy diet and a healthy diet that's full of fiber, lean protein. And if you're exercising a lot and you're under eating, we want to make sure, and you're on a GLP-1, let's say, we don't want you to lose muscle mass. So these are some tools you can use to bring in. Dr. Banihashemi, I'm going to get you to speak, briefly on omega-3s and fish oil. There's a bit more of a specific role for where do omega-3s fall and fish oil fall in a heart health plan.
Yeah, so with regards to the cardiovascular health of it, I mean, we have pretty good evidence, particularly in patients, higher cardiovascular risk patients with elevated triglyceride, as you pointed out on the slide. The Reduce It trial, randomized control trial, using icosapent ethyl, which is essentially EPA, at a very high dose to significantly reduce cardiovascular outcomes. Anecdotally, I'm sure we've seen it. It reduces triglycerides. We always knew that it reduces triglycerides. The question has always been, does it actually translate into cardiovascular outcome? And this randomized trial actually showed that it does translate in cardiovascular outcomes as long as it's in high cardiovascular risk patients that have elevated triglyceride. And then, of course, as I know that you love to talk about, is kind of the effect of DHA on the brain. So different types of omega-3, essentially EPA for cardiovascular health and DHA more for brain health and cognitive data and cognition.
Yeah, and sort of that kind of along the menopause lines as well, the dryness, the endothelial, like the loss of elasticity and collagen. You see stiffening of a lot of different areas. So fish oil, I like to always, if I'm prescribing something, make sure it's hitting multiple symptoms. So for mood support, memory, brain fog, focus, and dryness, that's where it works really well. So that's how we try to break it down a little bit.
Caution with caution with blood thinners with fish oils as well. I'm sure Ben is
Yes.
aware of that one as well. That's a big interaction that I
Yes.
warn patients. Just wanted to chime in there.
Um, and yeah, and again, if you are someone who eats fatty fish consistently 2, 3 times a week, then that might not be, in terms of where we want to add focus, that might not be the best area. It's really good for people that don't have a lot of fatty fish in their diet very consistently. Fiber is a big tool. All of the studies on all of the diets that have been shown to reduce cholesterol really are big and high in fiber. So fiber is really important. It's how you excrete cholesterol. Your body binds it up. You eliminate it through the stool since it's fat soluble. So supporting fiber in your diet is really, really important. Those plant sterols that you get in all sorts of fibrous foods are a critical staple. So a supplement won't replace that. But again, if you're hitting a wall with your amount of fiber that you have in your diet, fiber is kind of that like it'll help slow down gastric emptying, regulate your bowel movement. So again, these are kind of very core foundational pieces if we're looking to support overall health. Yes, there's the lean proteins in the diet, there's the fibers in the diet. This is how you can add and support with more specific outcomes. So you're looking for cholesterol reduction. And whenever we use supplements, if we are in that prevention or intermediate zone, we really want to make sure that you've tested your levels and that you're actually seeing benefit. We want to make sure that, if you are using supplementation for an outcome like cholesterol, and I got a question about bergamot, there's some interesting research around bergamot, or berberine or inositol, you need to make sure you're getting your levels rechecked in 3 months or 6 months to make sure that it's actually working for you, or else we're delaying access to another treatment. So we need to adjust and make sure you're getting the appropriate dose. CoQ10, Adam, I'm gonna get you to speak to us about CoQ10. Where does that, and I know you already mentioned CoQ10 and statins, so what's kind of the dose? And I had a question on it. That's why I wanted to bring it up.
The typical dose if you're on a statin to reduce muscle pain, and there are studies on this, and it does help, and I've seen it work with patients. Typically about 100 to 200 milligrams daily is pretty standard. Yeah.
And
And
should
it
someone,
helps.
oh,
Yeah.
go ahead. The question was, which is a good one. Should CoQ10, because we know it reduces CoQ10, we typically only prescribe CoQ10 for people experiencing side effects, but what if,
Well,
should
I
anyone?
often, if I'm speaking with patients at the pharmacy like counter, often I'll check for any issues or like what supplements they're already taking, but I usually recommend it if, for example, if they're starting on a statin. Yeah.
Okay. Yeah, so just preventatively.
Yep.
Okay. The one of the big shout outs is iron in women, heavy periods. Um, Iron depletion, low iron is very common, but it's not normal. The heart is responsible for pumping oxygen, but iron is what helps us hold and carry oxygen throughout the blood. So, low iron, dizziness, fatigue, short of breath, a lot of kind of cardiovascular symptoms. So, it's really important to understand where your iron levels are at and actually treat them if your levels are quite low. It can be very significant in your ability to exercise and move and feel energized. And it can reflect a lot of those kind of cardiovascular symptoms as well when you're low. Okay, we got through our content. We're gonna go through a little bit because there's a lot of questions on what should I do? Is it too late if I'm 8 years post-menopause? What should I do if I'm high risk? My doctor doesn't want to prescribe me a stress test. So I think this will cover a lot of that. Dr. Banihashemi, when we talked about what your clinic is, we had referred to this program before. The Heartwise for Menopause program. This is a collaboration between NutriChem and the Cardiac Longevity Clinic. We've specifically designed it for women to understand and stratify their risk a little bit more as we look at their whole picture and build more of a personalized plan. So you just need to book an appointment. I have the links. You'll see one of our naturopathic doctors in the clinic. We'll do our full assessment. We'll do the full blood work, and then you will get the referral through into Dr. Ben's cardiac longevity clinic. So we look at, again, when we talk about heart health, it's not just cholesterol. We have to look at hormones. We have to look at nutrients. We want to look at your inflammatory markers, your liver enzymes, your insulin levels, your blood sugar control. So it's a whole body story. The heart is really important. That's where we framed it, but we really want to make sure that for true personalized medicine, we're looking at the whole thing. And the nice thing about this is that when you get your testing done and if you'll get your stress test and any other tests that are recommended by the cardiac longevity team, you also get a full sit down with Dr. Banihashemi to go through your results. And that is something that we just don't have in our system, being able to sit down with the cardiologist and understand your heart risk, what you can do, how you can support yourself, and maybe you require medications, maybe not, maybe you can adjust your dose. Um, and Dr. Banihashemi, I'm going to let you speak to your clinic in just 1 minute. I'm going to keep this slide up for a second. So there's the QR code. That's how you can book in. You can just go to the NutriChem clinic page, fill out the form, write heart health. Our clinic team will contact you, so you can go through that channel. It's always on our website, like I said, under nutrichem.com under the clinic. And so that's, you can come in, you don't have to have a heart assessment. You can just come in and see one of our naturopathic doctors. Or if you are more focused on your cardiac health and that's more of an area you really want more support with, you can also visit the Cardiac Longevity Clinic. So do you want to give a brief little spiel on your clinic, Dr. Ben?
Yeah, thank you. Thank you, Dr. Pollon-MacLeod. But yeah, it's really about exactly what you talked about, is this idea that your body is really not individual organs, right? Everything that happens in every part of your body affects every other part. And really our idea in a cardiac longevity clinic is going beyond the heart and just managing heart disease, because we do know, as we talked about tonight, that heart disease starts with all of these other changes that happens in your body, whether it's your blood pressure, your cholesterol, your hormones, whether it's a metabolic disease as a result of developing visceral fat or reduction in your muscle mass or poor sleep. So what we've actually done in cardiac longevity clinics is really coming up with a holistic preventive type of program where we look at the entirety of your body and the entirety of your lifestyle, from sleep to nutrition to exercise. And we look at every part, we score every aspect, every major pillar, and we give you an actionable plan on every one of those. And we do that informed by data. So we do your cardiac testing to see if you have cardiovascular disease. We do a full metabolic testing on you, including the blood work as well as a DEXA scan to look at your body composition. So all the advice that you get is driven by data and driven by evidence, so that you can actually make an informed decision that would hopefully massively change the course of your longevity and your risk of heart attack and stroke.
And you like anybody is like anybody can come to your clinic. You don't have to be a woman, you don't have to be menopausal. The program, the Heartwise for Menopause is it's a specific program that's only eligible for patients that are coming through the NutriChem clinic, that we send the referrals in because we have more of a like a smaller little portion of the test because we have done all the metabolic testing. We're focusing on the lifestyle and the diet and that sort of piece. So it's kind of nice you get best of both worlds. If you're not sure, just reach out, just fill out the form, and we can help guide you to what's going to work best for you. Our clinic and Min are really excellent at kind of listening to what your concerns are, what your priorities are, and helping you find the path forward that's going to work best for you. We also put together a little heart health essentials collection. So there's the QR code to that, just so that it's easier for everyone to see the products that we chatted about today. I get that question after every webinar, so we decided to put it up, and we have just a little promo for you today. Coming up next, if you enjoyed this type of webinar that was more of a panel discussion, the next one, and we had so much demand for it, we've set our next panel. We don't have a date yet, but it's going to be an integrative panel on menopause and hormone replacement therapy. So we just touched on it briefly today. The next one is going to be Dr. Sophie Pollon-MacLeod, my sister. She's also an ND and a Menopause Society certified practitioner. Grace Meehan, an amazing clinical pharmacist. She's also Menopause Society certified. And Dr. Marina Strazik-Suri, who is a OB-GYN who has been practicing in community for 30 years. She is a wealth of knowledge in the hormone and menopause space. So they're going to have a collaborative discussion just like this one. So when we have that date set, we will make sure to let all of you guys know. And so I know we're kind of running out here, but what we'll do is anybody, you can type your questions in. For those of you who stay on, I'll continue answering questions. I'll go through them. Dr. Ben, we can maybe spend I don't want to take too much of your evening. We've already gone over a little bit. I'll ask a couple questions. Maybe we'll go for an extra 5 minutes or so. One of the questions that I got was interesting. Too late if we were already, so is it too late if we're already 8 to 10 years postmenopause? This is why we made the program. So specifically for women who they're still in that 10-year window, we can see them, do an assessment, understand are hormones even indicated? They may or may not be. But if there's problems with sleep, problems with mood, problems with body temperature regulation, then you're a candidate for hormones. We would send you through the menopause hormone program so we can get kind of the green check from Dr. Banihashemi to say, yes, this person would be a candidate, or no, not the best idea. What else? We also had, this is interesting. My statin dose was increased 6 months ago. Cholesterol has normalized. Is there a point where statin doses decrease? So do you ever drop someone's statin dose or remove someone off of a statin?
Yeah, so we would definitely consider doing that. Certainly, if there's been a significant body composition change. So, a perfect example is like a perimenopausal woman who goes on hormone therapy. So, a lot of times this kind of starts this positive cascade, right? So, they've gained a bunch of weight, their cholesterol is out of whack, their blood pressure is high, all these changes that happen in their body once they go on hormones. And then, I mean, there's a lot of other aspects that we didn't even talk about. They're not sleeping properly, they have joint pain. All these things have kind of led to them not exercising. So once they get on the hormones, then all of a sudden they get on this positive feedback loop where they are able to exercise. They do lose the weight. They eat better. They sleep better. So if there's a significant change like that, that can come about, for example, when people go on estrogen, then we repeat their blood work and look at their LDL cholesterol. If it's a significant drop on statin and they're way below that target that we consider kind of the target for treatment, then we definitely would withdraw it.
Perfect. There's a question here on supplements like L-arginine, citrus bergamot. So I can speak to bergamot. There's some really interesting, compelling research for cholesterol reduction. So again, if you're someone who's just starting to see increases, you're just starting to see levels rise, we can build a plan with fiber, bergamot, berberine, plant sterols, or another one, and just make sure that it's working and we're consistently not seeing your levels rise. And oftentimes, again, for someone who doesn't have a strong family history, they don't have a lot of other risk factors, they're trying to be aware of their cholesterol. Absolutely. If total cholesterol is completely out of range, your blood pressure is not being managed, your lipoprotein A is elevated, you likely need a stronger intervention and you need more of an assessment so that we can be more informed as to, are we playing with someone who's in a really high risk zone, or is this okay for us to take a little bit more time, maintain levels a little bit higher? So just really understanding that personal risk. And there's a lot of stuff we've alluded to, cholesterol, lipo A, blood pressure, understanding your metabolic health that can really start to paint that picture. I'm going to say this is our last question, so we don't go too late, but I like this question that someone mentioned is, how important is family history? So if someone has, mildly, I just had a patient with this actually yesterday, so this is why I'm mentioning this. Maybe mildly elevated lipids, maybe lipo-A kind of borderline, but they have, mom had a heart attack at 71, grandmother had a heart attack, like fatal heart attack at, mid 60s. Where does that shoot the risk up higher? What are your thoughts on family history?
So yeah, it's important to define kind of the family history of kind of what's considered significant family history, because I mean cardiovascular disease is so prevalent that if you kind of dig deep enough, most people have some sort of a family history. They've had somebody who's had a heart attack or a stroke. So really, what we consider significant with regards to genetic predisposition are for women younger than the age of 50, and for men younger than the age of 55. So if you have that kind of a family history of that age, so have heart attack and stroke at a younger age, particularly in a first degree relative. So those are kind of what we consider significant with regards to possible, because really what we're looking at is a genetic predisposition. Are you likely to have a genetic predisposition? In North America, unfortunately, with our lifestyle in the Western world, by the time you're over the age of 60, if you have a heart attack, we essentially blame your lifestyle way more than genetics when we look at, the large population studies. So first degree relatives for women if they've been younger than the age of 50, and for men if they've been younger than the age of, for women younger than the age of 60, for men younger than the age of 55.
Okay, and any sort of cardiac event.
Any sort of cardiac
Okay.
events. Well, I mean, coronary disease, right? So heart attack, primarily
Yeah.
heart attack, angina.
Okay.
Heart failure would be kind of different, kind of a different kettle of fish altogether.
Perfect. Okay, well, I think, as always, we could continue on forever, but I know it's late and everybody probably wants to get ready for bed and not be on screens too close to bedtime. So thank you so much, Dr. Adam Livingston, Dr. Banihashemi. This was such a great talk. I hope everybody enjoyed it. We will be sending out the recording. Thank you guys for all your engaging questions, and I hope you enjoyed it. Have a lovely evening.
Thank you.
Thanks.
Good night.
Bye, everyone. Good night.